Okay. Okay, it's 9:08. If you don't mind, I start. Um, we finish 9:58, hopefully, or maybe earlier. Okay, so first of all, they brought me this tea. I am sure the hospitality here, I have to say, it's very exemplary. I'm very thankful for everything I'm receiving here from the audiovisual to tea to everything. Perfect. So, Amir, last session, you told us what is the homeostasis of the potassium, how potassium is being handled. Now tell me, if the things go wrong, if the handling is not done well, what happens? That's this session. So the first session we said what is the normal physiology. Now we are talking about when the physiology is not working. Right? Okay. Do you want to just see if you remember from the last session? Okay, let's give it a try. A few questions. What is the main extracellular ion? We talked about it. Yes, it is a trick. I was waiting for you to say potassium, but it is sodium. Yeah. Okay. Where do potassium uptake and potassium exit take place in almost all cells? Very, very, very good. Excellent, excellent. Sodium, potassium ATPase is the uptake, and you know potassium channels that exit. Okay. What are the two main components of potassium handling? Very, very, very good. Excellent. Redistribution and excretion. Where is the sodium potassium 2 chloride co-transporter located? Loop of Henle. Exactly, exactly. TAL. That can be blocked by loop diuretics. And where is the major site for regulated absorption of potassium in the nephron? Yes, the thing is regulated. If I had not said regulated, it could be those three parts. But when I say where is the regulated part, I am looking at intercalated cells of the collecting duct. The principal cells are regulated excretion. Do you remember that? Are we good? Okay. And I don't go too much about it because these lectures, sometimes I give these lectures in 2 different days. That's why I put a lot of slides from the previous one to get people going. But for you guys, you remember that we want to keep our potassium between 4 and 5. Anything above that or lower than that will put us at risk. It has something to do with the membrane voltage, the cell membrane. Then we talked about two mechanisms, redistribution and excretion. We said insulin is important than that one, aldosterone for this one. Then we talked about redistribution. These are 5 things that will make the potassium go inside the cell. So it gives us hypokalemia, alkalosis, and insulin being the main ones. Then what are the ones that push the potassium out of the cell? It would be acidosis, low insulin, and cell injury. We talked about earthquake. Do you remember? Please. How it changes? It has something to do with the rate of the sodium potassium ATPase. Make it quick or slow, as easy as this. Even for thyroid, it's the same, right? Think about it. Each time it is faster, more potassium goes in. Each time it is slower, more potassium stays out. Does that make sense? Yeah. But it has something to do different from the regulated one that we are going to talk about. We are talking about now the unregulated one. If I alkalinize somebody, they are prone to hypokalemia through this. Okay? This is unregulated. We talked about the regulated one. We talked about RAS and we talked about angiotensinogen, and I go fast because it was just a couple minutes ago. So I told you here that here the aldosterone gives me potassium excretion and sodium absorption. So sodium goes in, potassium is out. Sodium goes in, potassium goes out. Think about it. Sodium goes in, sodium goes in. If I get a lot of salt, my blood pressure goes up or goes down. Yes. So if I have a lot of aldosterone in my body, do you think I am prone to hypertension or hypotension? Hypertension. What about my potassium? Do you think I am prone to hyperkalemia or hypokalemia? Hypokalemia. perfect if excessive hypokalemia or hypertension. As easy as this. You are going to have a lot of USMLE questions. They give you the guy calm, hypertensive hypokalemia. They want you the diagnosis. Look at aldosterone. And we are going to talk about it in a second. Okay, these are different medicines. This is new compared to the previous slide you saw. These are different medicines that block each of these pathways. You see, for example, here. God bless. Okay. Direct renin inhibitor inhibits this one. ACE inhibitor, angiotensin receptor blockers, ARBs, block this one. Mineralocorticoid receptor antagonists, MRA or MRB, BET blocker, sometimes they call it. They block this one, the effect of aldosterone on the principal cells of the kidney or intercalated cells of the kidney. So there are 4 different categories of medicine you need to be familiarized with or familiar with, where you have uh, this RAS system blocked in different parts of it. Okay, now that we know, let's go to our this session, hypo and hyperkalemia. Okay, hyperkalemia is when your potassium is over 5.5, and don't get involved in the numbers. Some people say 5, 5.2, 5.5, different numbers. Just above whatever the norm of that lab is, and hypo is when it is less. Typically, we say between 3.5 and 5.5 are reasonable. Anything below 3.5 and 5.5 starts to make us anxious. The farther from the norm, obviously, the worse. Okay. And potassium homeostasis, like anything else in the body, it is amazing, amazing. Basically, everything that goes in comes out. That's that's the bottom line. That's as easy as this. Think about it. Guys, have you seen some studies? They talk about 20,000 patients. They looked at the association between salt intake and blood pressure. There's a study in Sweden or wherever, 12,000. So how do they check the intake of the sodium of these patients? So let's say I am doing this research. I want to know if you have more salt, you will get hypertension. Okay. I come sit next to you. Okay. You had pancake. Today you have sausage. You have one by one for 20,000 people. How can you do such a study? They don't do this. They don't do this. You know what they do? They tell these people, bring us a jug of your urine from the last 24 hours. They take the urine, they go to the lab, they check the urine sodium. The urine sodium that is excreted over the last 24 hours is what has been inside. As easy as this. What goes in comes out. For the serum potassium to stay within the same limit, whatever I give them should come out. Sodium the same, magnesium the same, phosphorus, everything the same. Does that make sense? So use this principle and go to hypo and hyperkalemia. Okay, here, this is my imaginary person. Potassium intake, we said around 100 millimole per day, but it can be anything depending on your diet, right? Goes inside 100. Our serum sodium or extracellular fluid has 4 to 5. Here it says 4.2. There are redistribution happening. Some potassium goes in, some potassium comes out, and then excretion should be 100. 100 goes in, 100 goes out. Remember that? That's the bottom line. Does that make sense? Okay. This is all you need to know about hyperkalemia, hypokalemia. How do uh, I would say, apply this concept to hypo and hyperkalemia? Here we are. One problem might be here. If we have hypo or hyperkalemia, low intake, high intake. One would be redistribution might become a problem. Potassium that goes in or comes out. the urine potassium that is an issue, and the fecal or GI potassium that is excreted. These are the four sites. Any of these that go out will have a problem. What do we have here? Let's start with hypokalemia, when my serum potassium level is low. Number one is here. Remember? Low intake, starvation, fasting, anything. They go on food strike. You know what kills them when they go on food strike? The prisoners? Hypokalemia. They will have cardiac arrest. The potassium for the first few days, it is kept high because it is released from the muscles, right? From the store. Until the store goes down on potassium, they start to have low serum potassium, low serum potassium, 3.5, 3.1, 2.8, 2.2, 1.8, cardiac arrest. Does that make sense to you? Hypokalemia. Look, we are not talking about 13 hours of fasting or 2 days of, no, no, no. That will be coming out of the muscle. There will be no problem. You're talking about long-term starvation. Okay? Shifting of potassium into the cells, alkalinization. I you give me some alkaline, whatever, bicarbonate, and my potassium that was extracellular will be pushed into the cell here. I will have hypokalemia. Increased renal losses. You give me a loop diuretic. Sodium, potassium, 2 chloride is blocked. My potassium is gone into the urine. I will get hypokalemia. Increased stool losses. I told you about this. It should be major. We are not talking about a few episodes. You need to have a lot of stool for you to have hypokalemia. So you see these four, if you know everything about hypokalemia. Any of these, low intake, going into the cell, excreted by the kidney, excreted by the colon. These are the four. That's it. There's nothing more. And you know what? Let's go into a case. We always love cases. Would you do? Is it the case for you too? For me, every 10 years we have to pass a test, right? Every physician in US, every 10 years they have to pass a test to make sure that they are up to date. I never can read the whole chapter. I just go to the questions. The questions are more fun, at least for me. So, 35-year-old nurse is referred to, and this is a USMLE case actually. 35-year-old lady comes for severe muscle weakness. What do you think of muscle weakness for a nephrologist? Potassium something, right? At least I keep it at the back of my mind when somebody says potassium muscle weakness. Her serum potassium level is 2.1. Her husband suspects that she has been taking some pills to keep her weight down, but does not know the name. The ER doctor checks the urine potassium creatinine ratio. It is 25 millimole per gram. What is the most likely reason for hypokalemia in this patient? Low potassium diet, diuretic abuse, laxative abuse, undiagnosed diabetes. Okay, let's see what he has. Urine potassium is 24. What does that mean? I know that everybody that comes here and teaches you thinks that their organ is the best organ. The neurologist thinks it's the brain, the cardiologist the heart, and the nephrologist thinks the kidney. But during this week, you will see how smart the kidneys are. So, measurement of urine potassium can differentiate between renal loss and other losses. Basically, I want to know this low serum potassium, is it because there is a lot in my kidney or not? That's all I want to know at the first stop, and probably the only stop, as a matter of fact. Why? Because kidneys are smart. If I have hypokalemia, my kidneys, if normal, will not let any potassium in the urine. They will conserve all the potassium. Do you think my urine potassium will go down or will go up if my kidneys are normal in hypokalemia? Down. They will keep all the potassium in. They want the serum potassium to go back up, so there should be nothing in the kidney. Does that make sense? In normal physiology. Does that make sense? If I have normal kidneys, in hypokalemia, my urine potassium should be minimum. Does that make sense? Okay. Urine potassium to urine creatinine, we call it this number, you need to memorize it. Less than 13. And please, in nephrology, pay special attention to the units. Millimole per gram. Millimole of potassium to gram of creatinine. Why did I bring creatinine into the mix? Isn't it already complicated, this potassium thing? Now I'm talking about urine creatinine. Remember, everything that you are going to proteinuria, we have potassium. Here, when we talk about potassium, we have urine creatinine. You ask yourself, why urine creatinine? I tell you once, if you get it, good for you. If you don't get it, don't worry about it. It's not for the, it's not important for your USMLE. Think about a day that I am drinking like crazy. You're not crazy, but look at the bottle of water in front of you. It's really big. You're drinking a lot, right? So if I check your urine potassium, do you think it will be dilute or not? So your urine potassium, no matter how much potassium you get, will be on the lower side, right? Think about another scenario. You don't have that bottle of water and you're outside jogging. If I check your urine potassium, do you think it will be low or high regardless of what you have had as potassium? It's high because your urine is super concentrated, right? So the concentration of urine changes the concentration of whatever we are checking, like urine potassium or urine sodium or urine protein or urine everything. We need something to adjust for the concentration. We need something that is, no matter what is in the urine, at the constant rate. Meaning that if my urine is concentrated, it goes up. If my urine is dilute, it goes down. It is not changing every day. Urine creatinine. So you are going to see urine creatinine in many of our measures here. This is because we adjust for concentration, dilution of the urine. If you got it, good for you. If you didn't get it, you don't need it. So what you are going to memorize is that urine potassium to urine creatinine, if it is less than 13, it tells you that the kidneys are perfect. You have hypokalemia, and the kidneys are conserving all the potassium. There is no potassium in the urine. Perfect, right? Less than 13 millimole per. So you know that it is non-renal loss from anything else. You can say redistribution, it is GI tract, it is whatever, but it is not the kidney. Would you agree? Okay. So in this case, which one of these is, it was 24 for that lady. So if I have low serum potassium, but there is a lot of potassium in my urine, what does that tell you? It is renal loss, right? Which one of these is renal loss? Low potassium diet, diuretic abuse, laxative abuse, diabetes. Diabetes, let's put it out of our way. Diabetes, are they prone to hyperkalemia or hypokalemia? They have low insulin. Hyper. Do they have anything to do with the urinary excretion of potassium? Does it increase the urinary potassium or decrease? Diabetes has no effect on the urinary potassium changes. So this is out of our way. They just put it here because they didn't have a better distractor. Basically, we are between these three. Low potassium diet, diuretic abuse, or laxative abuse, and she has had a lot of potassium in her urine. 24. Normal is less than 13. So what do you think the answer is? Diuretic, right? The lady is enjoying her loop diuretic, furosemide, sodium, potassium, 2 chloride, blocker, right? What happens is that there is a lot of potassium in the urine. So the patient gets hypokalemia and the urinary potassium doesn't come down because that medicine is blocking the sodium potassium chloride. So it is a urinary loss. Does that make sense? Does it? Some of you don't seem to be convinced. If you are not, come to me after the session. Okay. Should we go for another case? Let's go for it. It's a difficult one because you haven't had everything. The nephrology part is easy, but the other parts, because you don't know everything about all systems, it might be a little bit challenging. 24-year-old gentleman, urgent care, 2 days of acute onset of muscle weakness. Red flags go up for nephrologist. Could hardly get out of bed and cannot walk. 24-year-old, why can't you go out of your bed? States that he has lost 30 pounds over the past 2 months. He mentions he loves pasta. Who doesn't? Carbohydrate and eats it daily. Physical exam is normal except for diffuse muscular weakness. Are you familiar with this form of labs? This is called a skeleton labs. So this is the rule. You probably need to learn it for the future. Sodium, potassium, fluoride bicarbonate, BUN creatinine, glucose. And you're going to see it very much in other things. So what is the potassium? Potassium is 2.6. Hypokalemic he is. He's hypokalemic. Okay. What is the diagnosis? Diuretic abuse, thyrotoxic periodic paralysis. This is so once in a while the thyroid secretes a lot and they get paralysis. Aldosterone secreting adrenal adenoma is the fourth, and laxative abuse. One of these four, he has it. We want to know which one. What is a good lab to check in hypokalemia? I just told you about urine potassium, urine creatinine. We call it spot urine because it's one sample, it's not 24-hour. Spot urine potassium, spot urine creatinine. Should we do that? Okay. Let's do it. Let's see if the kidneys are conserving the potassium, the smart kidneys. His urine potassium is 16 millimole per liter. His urine creatinine is 2 grams per liter. If you put these two, liter with liter is canceled, you will have millimole per gram. Be careful with the units in nephrology. Be careful. So urine, so it is 16:2. Urine potassium to creatinine ratio is 8. There is no renal loss. Would you agree? It is less than 13. We said if it is less than 13, the kidneys are doing a good job. They are keeping the thing. So it is not. So let's go back. What do we have here? Do you think it can be diuretic abuse? Do you think this guy might have been taking some diuretics? No, the urine potassium is low. If it was diuretic, just like that lady, it would have been higher than 13. What about the other ones? What about aldosterone secreting adrenal adenoma? The aldosterone to the principal cells, and it is sodium is going in, potassium is going out. Do you think it can be the case? Again, no. The urine potassium is not high, right? I agree with you. I agree. So it is thyrotoxic periodic paralysis. That's what I told you. You don't know it, don't jump up. Just think about the concept more than the answer. Do you remember I told you that thyroid pushes the potassium inside the cell? It's kind of a funny diagnosis, at least for us, not for the patient, probably. When they get pasta, for some reason, the thyroid starts to secrete a lot of hormone, pushes the potassium inside the cell. They get paralysis. They say it is very common. I hope they're not in Italy. They eat pasta every day. So they say each time I eat a big load of pasta, I get weak because insulin is, thyroxine is secreted. The potassium is pushed into the cells for a few hours, gets hypokalemia, is paralyzed, then gets better, lives his life. Does that make sense? So the urine potassium does not go high. It's not a renal loss, it's redistribution into the cells, right? It's not excretion, it's redistribution. Does that make sense? So again, don't get involved in the diagnosis and I didn't know what is thyrotoxic something something. Just think about the concept of it. Very good. So why did I put this avocado here? Because avocado has a lot of potassium in it. I don't know why. It's not beautiful. I put it there. Remember here? Do you remember this? give you hypokalemia. And it is temporary. A few hours later, the potassium that was pushed into the cell will come back. Normal serum potassium lives his life. USMLE buzzword. Young age, carbohydrate use which gives you insulin, periodic hypokalemic weakness, thyrotoxic periodic paralysis. It works through the thyroxine and insulin. Basically, you have somebody who is young, once in a while has muscle weakness, and it tells you somehow it is associated with carbs, with pasta, with something like that. Then it is thyrotoxic periodic paralysis. Should we go for another case yet again? Let's go for it. 52-year-old lady comes 1 month history of headache, weakness, tingling of her extremities, muscle cramping, what high pressure, blood pressure, 170 over 110. Physical exam, no other abnormalities. Serum potassium is low, metabolic alkalosis, decreased plasma renin activity, serum sodium, all that, so many things. Urine catecholamines, the sympathetic nervous system are within normal range. Which is the following? Which of the following is the most likely diagnosis? And that's a classic USMLE. I took it from these books. Adrenal adenoma, focal segmental. It is a form of glomerulonephritis. Have you had this, or it is next week? Actually, it's a form of. It is actually today. You will have it a small group, but okay, Dr. Danish will tell you next week. It is one of the immunologic diseases of the kidney. Hypothalamic tumor, juxtaglomerular cell tumor, where the renin is secreted. Renal artery stenosis. Okay. Again, you don't know many of these, but it doesn't matter. Think about the concept. I didn't bring you this question to make the question right. Actually, on Friday, all you and I we do is 2 hours of doing USMLE questions. So, but for these ones, just the concept is important. This is all the things that are wrong with her. Let's take a look. Weakness, tingling, muscle cramping, fatigue, okay, high blood pressure, hypokalemia, low renin activity, and the rest is nothing. Okay, low renin activity, hypertension. Okay. Do you remember this concept? Do you remember that I told you if you have any of this is high, will give you, if aldosterone will go up, and if you have high aldosterone, it will give you hypertension, hypokalemia. Did I tell you that? And we went through it. Why? Is it as if there's a lot of salt coming to the distal tubule? Everything is absorbed. The sodium is absorbed, so I get hypertension. A lot of potassium will be secreted, so I will get hypokalemia. Hypertension, hypokalemia next to each other would be aldosterone that is high. And if you want to me, that was the sophisticated one. AK version, Amir Kazory. My version is this. When renin goes up, aldosterone goes up, just like any other feedback system that we have in the body. When aldosterone goes up, it comes down the renin, right? That's how it works, this loop. So renin goes up, aldosterone goes up, and when aldosterone goes up, renin goes down. Think about it, it makes sense. Okay, so it is adrenal adenoma. You know why? Because this patient has an aldosterone that keeps secreting. It is not regulated. So I have an adrenal adenoma, regardless of my renin, regardless of everything else. I have a tumor. It is secreting aldosterone. It gives me hypertension. It gives me hypokalemia. It also gives me low renin. It suppresses the renin, right? That's what it does. When aldosterone goes up, renin is suppressed. Actually, renin is not measurable even, right? Does that make sense? So, if you want to put all of this together, again, you will ask yourself, why isn't it renal artery stenosis? Why isn't it? You will hear about this later. But for the sake of our concept, you remember that high aldosterone will give you all of these. Especially what is very special about this case is low renin. That's why we call it primary hyperaldosteronism. The problem did not start from upstream. It started from the aldosterone itself. It started to secrete a lot. It suppressed renin. USMLE buzzword, this one you need to tattoo it in your brain. Really need to. There's a lot of questions on this. Resistant hypertension. This is a hypertension that is difficult to treat. Then you have metabolic alkalosis. Do you remember metabolic alkalosis? Why is it? Intercalated cells. Do you remember? Potassium was absorbed, hydrogen was secreted. You get alkalosis, right? Hypokalemia, we know why. High aldosterone, low renin. High aldosterone, low renin. You have all of these. They're very nice if they give you all of these. They might give some of these, like this case. It would be primary hyperaldosteronism. There is an adenoma, there is a tumor, there is something in my adrenal that is secreting aldosterone. Primary hyperaldosteronism. You know about this, I have told you already. EKG changes with hypokalemia. Look at this. Look at this beauty. This is the usual. I have to stay here. This is the usual normal EKG that you are very familiar with. Look at here. What do we call it? U wave. We have PR, we have T that has changed, but U wave is characteristic of hypokalemia. And for hypokalemia, you check the serum level, you see it is low. You don't need much to think about it. It is more for hyperkalemia that it is. What's the treatment of hypokalemia? It's easy. First of all, just like anything else, treat the underlying cause. If it is an adenoma of the adrenal gland, you need to remove it. Or if it is loop diuretic, you need to stop it. It's really not rocket science. But what about the treatment? Oral is always safer. Potassium chloride we give, and if it is severe or symptomatic, we give intravenous, right? Nothing really big. There's really nothing here to worry about. What about hyperkalemia? The same concept applies. What goes in comes out. You have four different spots to look at. Actually, it makes it a little bit easier because GI tract does not have a major role in excretion of potassium. It cannot play a role in hyperkalemia. Even if my GI tract completely stops excreting potassium, no impact, no clinical impact on my serum potassium levels. So instead of four aspects to look at, like hypokalemia, here we have three. One would be, again, the problem with intake. One would be the redistribution. One would be with the kidney. And this time is different. Increased intake for hyperkalemia. I take a lot of tomato juice. All the things that I told you are very helpful and very healthy. If I have kidney disease, I should slow down. I have dialyzed the patient because he got a lot of bananas. Who in the world goes and gets 6 bananas a day? He was doing it because he had heard it's very healthy, right? So increased intake. Juice is the worst thing. You know, one glass of orange is 5 oranges. So when you drink it, you are equal to 5 oranges of potassium you're getting the inside, right? So just keep that in mind. Tomato juice, fat, potato. You know, one way to get potato without it potassium for our patients, you know what I tell them? So you soak them in water the night before. You put the potatoes in the water the night before, all the potassium goes inside the water. So then you use that potato. Would be a low potato potassium, right? Low potassium potato. You know, one thing that my patients love, the patients that are on dialysis, they cannot have is what? French fries filled with potassium and salt, but they can't have it. Some of them bring their bag of French fries to the dialysis unit. They eat it while they are being dialyzed. Okay. Shifting of potassium outside of the cell would be another one for hyperkalemia. And then this time, decreased renal excretion, renal failure, or chronic kidney disease. My kidneys are not working appropriately. They are not getting rid of toxins. We are talking about the CKD on Wednesday. We'll talk about it later. But the point is, on Thursday, sorry. Uh, when you have low excretion of potassium, if you take a lot of potassium, you cannot get rid of it, right? You have a tendency for hyperkalemia and shifting of potassium out of the cells. Alkalinization pushes it inside. Acidization or acidic serum will bring it out, like lactic acidosis. Patients that have major sepsis, they come with lactic acidosis. They have a tendency for hyperkalemia, not because there's a lot of potassium inside their body, just the potassium that was inside the cell is coming out. What's their treatment? Alkalinization pushes them back inside the cell. If redistribution brought it out, I do the counter, it goes back in, right? That's the treatment. Should we do a case? Let's do it. 65-year-old lady referred to ear feeling weak, tired, diabetes, heart failure, severe chronic kidney disease, and is on lisinopril, which is an ACE inhibitor. You remember that pathway? Spironolactone, which is an MRA, mineralocorticoid receptor antagonist. She has been eating large amounts of potatoes, tomatoes, iced tea for the past 4 or 5 days. Lab studies show, oh boy, potassium of 8.2. Okay, and it is not unusual for us. What are the potential contributors to hyperkalemia in this case? Severe chronic kidney disease, excessive potassium intake, ACE inhibitor, MRA, all of the above. Which one would you go for? All of the above. If I told you high aldosterone gives me hypokalemia, then the other way is also correct. Blocking the pathway of RAS will give you hyperkalemia, right? Any of those four groups of medicine that I told you, they block the pathway, will have a tendency for hyperkalemia. Here, ACE and MRA, both of them are here. Excessive potassium intake, tomato, all those. Severe chronic kidney disease, she cannot excrete the potassium. So all of the above makes sense to me. So this is again a reminder for us that all of these will end up giving us getting rid of potassium. So the medicines that block this will give us retention of potassium. So all of the above would be correct. So what are the EKG changes of hyperkalemia? This is, as opposed to hypokalemia, is super important. Hyperkalemia. Basically, you start to have peaked T waves. This is the normal. Starts to go a little bit peaked. Then it becomes, so I show you here, peak T waves. You see it here. Flattened, it goes away a little bit, the P, and then prolonged PR, QRS complex. Look how it looks like. It looks like this. It says progression is poorly predictable, not meaning that I cannot look at somebody's EKG and say what is their potassium. But the reality is that it is rare that you start to see around 7, 8, and you don't see some EKG changes, whether it is the T waves that are the first and most important part, or going all the way to this sine wave pattern that you see looks like this. Okay, keep that in mind. Flattened P and the prolonged PR also important. But peak T waves, I put it in red so you tattoo it in your brain. Peaked T waves are a sign of hyperkalemia, the very first sign. Even a nephrologist will jump when it sees this. Look at this. These T waves are higher than the QRS. This patient probably has a potassium of 8, 9. What is the treatment of hyperkalemia? Goes with the physiology, this one. Number one is let's let's buy ourselves some time. Let's just block the impact of potassium on the voltage. We are not changing the level. We just want to block the impact on the cell membrane. We give ourselves some time to do something. So number one is giving the patient calcium. The onset is 1 to 2 minutes. In 2 minutes, you are good, right? does not affect the serum potassium level, but it stabilizes the membrane. So at least the heart doesn't stop working, right? Gives us some time. Second is pushing the potassium inside the cell. Let's just bring down the serum potassium by pushing it into the cell. How can I do it? Does insulin work? Very, very good. Just when you give insulin, you should go give glucose so it doesn't get hypoglycemia, right? You give insulin, beta 2 adrenergic agonist. Do you remember salbutamol I told you? And also alkalization. The three of them will push the potassium. It doesn't get rid of the potassium outside of the body. It just pushes it into the cell. We will have time to do something. Okay? Now it's time to remove the potassium from the body. We talked about one of them is the binder. It is K-exalate, or there are two others that I'm going to add. These are exchange resins. This is through GI, goes inside the GI, takes the potassium out, gives something in exchange. For example, this is a resin. The K-exalate is a sodium potassium exchanger. Takes the potassium out, gives the sodium. Takes hours. Remember, it is not something you do the first. It is after you have done the previous things, right? Patirom and zirconium are two other ones. Diuretics get rid of the excess potassium through the kidneys. Stop sodium potassium 2 chloride. Give them loop diuretic. So the potassium in the urine will be lost. And if nothing helps, we have to dialyze the patient. In dialysis, we remove the potassium mechanically, and we talk about it later. So, these are the exchanges. This is just for you to know. Nobody asks you to learn all of these. I just want to remind you that these are exchanges or binders. They get something they get potassium in exchange for something. Two of them would be sodium and one would be calcium. Again, this is just for information. There's really nothing for you to memorize. Let's do a case. I love the case. We have a 63-year-old woman is referred to the ER. Guys, think about this very well. Do yourself a favor. That's important. 63-year-old woman is coming to the ER. And just to tell you that I am not making it up, I put the labs the way we see it in our hospital. You see the date, you see the timestamp. This is really a real case that I saw in the hospital on 2022. Okay. CCGL1 is referred to the ER for feeling weak and tired. She has advanced chronic kidney disease, hypertension, heart failure. Lab studies show serum, oh boy, 8.8. Her EKG is shown. Should I be worrying about this EKG or is fine? Because if the potassium is high, it's a lab. If it doesn't have an impact on the heart, that's fine. Is it fine? Should I pass on this or not? Should I pass on this? Almost dying, this patient. It's a matter of few minutes, this patient. Look at the T waves, and they're starting to prolong. This patient is at imminent risk of death. When you see this, you stop everything else that you have, you come to see this patient, and you see these are the real labs. Look at the potassium. Potassium 8.8. I didn't make it up. Are we good so far? So here are my questions for you. She receives one medicine in the ED for management of hyperkalemia. Her EKG 1 hour later is shown below. Which of the following medicine is more likely to have been administered to this patient? You remember that ugly one? Look how beautiful it became. What did you? Before you go, calcium gluconate. Anybody wants to pick another thing? One person, one of you also go with four. Very good. Two people have gone for four. Four, you guys go for. Somebody else comes up with something else, something better. Nothing is better than what they said. Number four is the way to go. Thank you. Yes, calcium gluconate within 1 to 2 minutes. I told you that person with that EKG prolongation, she was going to die within a matter of few minutes. The first thing they did, they gave calcium gluconate. Everything got better. And you see it under your eye. Are you good? Okay. Okay. Calcium gluconate was the answer. Thank you. So if she has not received any other medicine, she just got the calcium gluconate, okay? What is likely to be her serum potassium level at this time with this beautiful, look at this beautiful. In the past, the T waves are here. So what is the serum potassium level now? Yes, that was a trick question. The serum potassium is the same. Calcium does not change the level of potassium. It just stabilizes the cell membrane as you see. Are we good? Perfect. So it is still 8.8, hasn't changed. So the question is, am I telling you bogus or hyperkalemia is really a killer? It is a killer. Actually, we use it to kill people, unfortunately, right? So if you go to Lake City Correctional Facility in Florida, Florida is one of those that has still death sentence, right? You see on the wall, this is what you should give for execution. Okay, potassium chloride. If you want to make sure that the heart of somebody stops, give them potassium chloride. Here is the irony about it. How much potassium chloride are they giving to the person? 100 is what you and I get every day. Just 100? And they say, keep 50 for the future. You see? Hold another 50 as needed. Right? So I just told you we get 100 millimolar of potassium. So why do they think that 100 millimolar of potassium will kill this patient or this person? 100? At least give 500. Why 100? 100 is what you and I get. What's the difference? What is the difference? You get 100, he gets 100, he dies. He doesn't have any time for handling of potassium. You give the 100 in a matter of seconds, right? But the 100 that you and I we get is not IV. We get potassium pushed into the cell, into our urine, into the GI, right? You see the basically the guy will not know who injects it, but you and I we know that they are removing the possibility of handling of potassium from the inmates. That's all they're doing. And just let me tell you, these other medicines you see here, they're all sedatives and all those. They are not killing anybody. These are sedatives for him not to have any pain. What kills him is the potassium. And what kills him is the lack of possibility of handling it, homeostasis. Does that make sense? So what I was telling you is not bogus, it's real. Hyperkalemia kills. Another thing you and I we need to know is a spurious serum potassium levels, meaning that, yes, you can check serum potassium level, it will be through the sky. Yeah, yeah, yeah. But it's not through autopsy. They're doing it on purpose. There are people watching it actually. Right? So spurious serum potassium levels means that in our body, we have normal serum potassium levels. After you draw it, you send it to the lab, they give you an erroneous result. Because after you draw it, something has happened. There are two situations. One is pseudo hyperkalemia, and one is pseudo hypokalemia. Pseudo hyperkalemia, you should remember that we have a lot of potassium inside blood cells, platelets, white WBC, RBC, right? So if I have a lot of WBC and you take my blood, you put it here, it waits until this afternoon before you check my serum. Is there a possibility of some of this potassium leaking out and give you a level that is higher than what it is in my body? It definitely is. So do you think somebody who has leukemia has your WBC's 8,000, his is 800,000. Do you think he is prone to have pseudo hyperkalemia or not? Happens so often. Even the oncologists themselves, they know it. What is the treatment? The thing is that as soon as you take it out, take it to the lab. You shouldn't let it stay around. And I send my patients to the core lab. I tell them, because they have leukemia, you cannot go to the lab on the Archer Road. You should go to the core lab, because Archer Road gets all the labs, keeps them somewhere at 5 p.m., sends it to the core lab. Core lab does it within minutes. Does that make sense? Do you see the difference? So, if somebody has thrombocytosis, if somebody has leukemia, cellular potassium release during clot formation will give you a spurious serum potassium levels. Interestingly, WBCs can also absorb potassium. So if you are putting the serum out and there is enough time for the WBCs, they might start absorbing it back. So people with leukemia are prone to both pseudo hyperkalemia, pseudo hypokalemia. Does that make sense? And we don't know which one. We just know that people with high platelet level, high WBC, you'd better check their serum potassium level immediately after you have drawn the blood. Does that make sense? Does it? Or you want to get rid of myths at the end of the session? Very good. I think we're actually at the end, right? So leukemia can be associated. Perfect. Actually, we're done on time. Thank you so very much for your attention. If you have questions, please come here. I'll be happy to answer.